Hello and welcome to the RSM Live webinar series. This is our 41st in our series of our COVID-19 for health professionals by health professionals. I'm Claire Bainton, the incoming Vice President of the Royal Society of Medicine, and I'm a clinical consultant in global public health based at LSHTM, London School of Hygiene and Tropical Medicine, and I also am a consultant at Public Health England. I invite you to use the Q&A function button, which is at the bottom of your screens. And if you upvote specific questions, then they are more likely to be seen and addressed. I do regret that we are unable to address all the questions that will come in. And we do have a wrap-up session with a panel where we will address outstanding questions on key themes in due course. So for those of you on Twitter, you can join us in the conversation at #RSMLive. So today we will be joined by Professor Devi Sridhar and Dr. David Nabarro. Devi Sridhar is Professor and Chair of Global Public Health at the University of Edinburgh, and she is Director of the Global Health Governance Programme. Devi is a member of the Black Professors Forum, and also inputs into the UK Scientific Advisory Group for Emergencies, SAGE, as well as an advisor for the Scottish Government. Welcome, Devi. I'd also like to welcome David Nabarro. He is Special Envoy to the WHO Director General for COVID-19. He is also co-director of the Institute for Global Health Innovations at Imperial College in London. David is a medical doctor who has made his career in the international civil service. He has been special envoy to the WHO and was involved in the Ebola outbreak in West Africa and to the Secretary General of the United Nations. And so I would like to invite you both to share with me some of your insights and updates of the key issues at the current time. Devi, can I invite you first?
Hi, good afternoon, and thank you for having me. I guess just to open up to say that I think this crisis has showed global governance, hopefully at its strongest in terms of how we're trying to see international institutions like the World Health Organization, the World Bank, CEPI, Gavi. I guess we'll go through all these acronyms and what these institutions are doing. You know, Gates Foundation, Wellcome Trust, different institutions that we've studied for a long time, actually having to, really step up and work at a pace and scale that we've not seen before for an infectious disease outbreak in recent years. And so, yeah, I look forward to taking your questions and having a fascinating chat with Dr. Claire Bainton about these issues.
Thank you, Devi. David, can I invite you to share your thoughts and updates?
Thanks very much indeed. Some people have said that the world should have realized that something like COVID was going to happen and should have been better prepared. But having watched how societies and institutions react to new infections, I've seen that there seems to be almost an inevitability about our inability collectively to get it right without a lot of difficulty. And if we don't get it right, then the consequences can be quite disastrous. So my present focus is on the narrative. Why on earth are we still seeing national governments presenting their political choices in terms of the economy versus public health? When for me, it's pretty obvious that economies can't be strong if public health is not secured. And so what I'd like to do, as well as looking at the behavior of the institutions, I'd also like to look at what has prevented us who work in public health from being able to establish a narrative that seems to make sense in the context of the political choices that are going to be made now and in the coming 6 to 12 months. I'll develop that during the answers to your questions. Thank you.
Thank you, both of you. And certainly public health is always political, but we should be influencing politics and political decision making when it comes to a pandemic rather than being at the mercy of it. So can I ask, the major global actors, and Debbie, you touched on a few of those in your opening, how are they adapting their remit and how are they collaborating? And drawing the distinction here, perhaps with how nationalist, populist politics are setting in, shall we say. Thank you.
Yeah, so I think, it's hard to not talk about the World Health Organization because it is the focal institution through this crisis, though there are other institutions as well trying to support on various other problems associated with it. And the WHO has really taken, if I'm being frank, a beating over the past couple of weeks because, for example, the United States or other, Brazil, countries are looking for someone to blame. People are angry, they feel frustrated, and everyone, especially as the economic impacts hit, need to understand what went wrong, and it's very easy to point the finger at WHO. But I think this misunderstands the role of the World Health Organization and what it can and can't do. So it really has three roles when you have a health emergency. The first is a legal role through the international health regulations. And there, what it can do is, have a country report that it has some kind of new pathogen or something worrisome, which China did in late 2019. Then it can let other countries know about this, which it did in early 2020. And then the highest alarm bell is a public health emergency of international concern. And it did ring this alarm bell January 30th and told the world, wake up. And at that point, it's up to countries to prepare or not to prepare. WHO cannot go into countries and force them to prepare, and it cannot, both criticize, countries for not doing it. They basically said, this is an emergency, wake up, this is the highest alarm bell we have. The second role is technically it tries to support countries. And so since January, having briefings where it explains what's the latest science, trying to, put aside misinformation, trying to have sharing of information across countries, sending a mission to China in February to draw out a bit more about the characteristics of this virus, the profile of who it was affecting, the epi profile, as well as what the Chinese response had been. That was a joint mission with the Chinese government, and then sharing that with the world so other countries and governments could understand what was done. And they've continued their technical briefings, and they are considered, technical. They're led by technical leads. And the third is a convening role where it tries is to bring everyone to the table, all countries, through a kind of independent forum to say, let's discuss how we move forward. And they did this year in May at the World Health Assembly, where all countries agreed to a resolution committing to global public goods and to collaborate for COVID-19. So that's what it can do. And it can't do anything more or less than what it's mandated to do. So I think I just wanted to use my comments in WHO to kind of put aside any of the, I don't call it misinformation, but kind of people don't really fully understand, why didn't China, why didn't WHO blame China? And why didn't WHO do this? And why? And I'm like, well, it's not what they do. This is what they do. This is what they can and they can't do. You want to have some other kind of organization, and you need to talk about how you either, expand those within WHO or create other forums to do those. So I'll stop there. We can talk about other ones like the World Bank, but I want to give also David a chance to reflect given his close work with WHO.
Thank you. David.
Thanks very much indeed. Do you know, during the last 2 months, Tedros, the Director General of WHO, has really tried to be extremely precise on what's happening. And he's explaining repeatedly that this new virus is not going to disappear. It's here to stay. And it's changing the viral ecosystem within which humanity is operating. And because of the particular nature of this virus, it's going to require quite significant shifts in the behavior of around 7.8 billion people. And currently, we're all in the midst of an enormous sense-making exercise, working out exactly how are we going to manage this. And it's quite a struggle. And in the midst of this struggle, we have vast numbers of businesses not quite clear whether they can survive or whether they're going to go under. We've got a lot of governments who are really worried about their economic future, not just the rich ones, but the poor ones as well. And we've got a huge increase in the number of poor people in our world. Now, the narrative that's going around from leaders is, okay, a vaccine will come, it'll be shown to work, it'll be administered, problem will be solved, and we'll be able to get back to some semblance of normality. And Tedros is saying, hang on a bit. You know, we've been trying for a vaccine for HIV for several decades, and we've spent billions, and we haven't got one. And there's no certainty that we'll have one or more really useful and safe vaccines against this COVID. And Tedros is also saying the future is about societies being able to live with this unwanted new member of our ecosystem, and we're going to have to define our future in terms of our collective ability to hold the virus at bay, whilst at the same time getting on with life. And so I want to stress to you, that trying to make certain that there is broad understanding of the inevitability that we'll have to go on dealing with this virus, and trying to get everybody to understand that we'll have to do that regardless of what happens in these phase 3 vaccine trials, is the big challenge now. And if we get it right, there's a chance that humanity will come through this stronger and be better equipped to deal with some of the other existential crises that we have to deal with. If we get it wrong, then the prospects for the next year, economic prospects particularly, for poorer people are really bad, because this COVID is becoming a disease of inequity. It's really biting into poor communities, biting in to poor countries in a really tricky way, and proving to be hard to dislodge. So shifting the narrative and then bringing nations and institutions behind that narrative is really important right now. And WHO can do it as an institution, but it needs the collective of the public health communities around our world hooked into it, so that together we get the message right and we help to prevent what could be a massively increasing, intense catastrophe for the world's poor people by this time next year.
Thank you, David. And they are very strong and poignant words and terms that you have used there. I want to return to Devi's points about the international health regulations. So the international health regulations, it's a legal instrument that's there to protect populations during health emergencies. And it has a special remit in regard to minimize the impacts of health on trade and travel. And I have a question here. Given the fact that sovereign states and commercial travel interests are all playing their influencing roles, and does WHO, and this is the question from Li Wu Chalon, who's a midwife, does the WHO attempt to coordinate or standardize the international threshold for travel and quarantine for travelers? Do you know that, Devi?
David would know, I think, better than me the exact, advice that was given at different times. I mean, I think what has generally been the case with the IHR is you try not to have too much disruption in regards to outbreak control. And I do think what we did see early on is because there was not clear travel advice given around movement of people in January, that countries kind of each implemented their own measures. So South Korea started, screening passengers from January 3rd or 4th. The United States brought in restrictions against, travel from China in late January. So you kind of got a free-for-all where every country was just kind of putting in different measures of restrictions, whether it was to all passengers coming in or passengers from certain countries or passengers from certain parts of certain countries. And so personally, I don't think we've had a standardized way of dealing with the international movement of people. in the world, let alone even in Europe. I think currently every country is kind of playing it by week and by month and trying to balance their needs, let's say in terms of tourism. I'm thinking of Spain and Greece and Malta, needing that, given its component in terms of its important component in terms of GDP, with actually your borders being one of the key measures to prevent the reimportation of the virus once you get numbers quite low. So I think this is one of the most tricky parts of COVID-19, because the countries that did well initially in their responses, and I'm thinking in Europe, let's say Greece and Malta, Faroe Islands, Iceland, generally island states, did so through having very strict restrictions on who could come in, and then having extensive testing and tracing, and then clearing the virus, basically eliminating community transmission. But at some point they have to open up to the wider world. We're all interconnected. I know there's pressure on New Zealand and Australia in a similar way. So that's, I think, a really difficult one, which is once you get a handle on the problem yourself and within your country, and that just shows how interconnected we are. If the pandemic is raging globally and other countries are heavily affected, you're going to continue to be affected, and you're going to continue to see cases, and you're going to continue to struggle with it because you can't close yourself off from the world forever. But at the same time, if you open up fully, then it becomes, how do you actually stop that community transmission and get your domestic economy going and make sure the virus doesn't get out of control again? So it's a really tricky one. I haven't seen WHO provide strict guidance about it recently, aside from their suggestions to countries on exit strategies saying, make sure you don't keep re-importing the virus, and have some guidance on how you want to do that, whether it's quarantine or testing at airports and several days later.
Thank you, Devi. And it certainly begs the question of the need to revise the IHR in terms of what we've learned. David Heyman has always explained that when they were first, and reviewed by him and his team in 2003 in response to SARS, we didn't have the surveillance ubiquitously available in the way that we do now, surveillance of cases and analysis. So the reporting that you've described as focal points is no longer quite so needed. So another role for IHR, which falls under WHO, may be critical. David, in response to some of the points that you raised, we have a question here from one of my colleagues, Carol Presern, who's a leader in public health and an academic. She asks, what is the impact, if any, of the US attack on the WHO and on its ability to respond effectively? David, you're just muted at the moment and gone.
There we go. I'm pressing the wrong button.
No, thank you. You're welcome. You're back.
Thank you, Claire. First, just a quick pick up on the last question, but using my WHO hat. It's really, I think, helpful that you've picked on this really odd situation we have at the moment, where the decisions made about travel between countries appear to be somewhat ad hoc. And it would be reasonable for any public health person in Britain to say, why on earth does it appear to be so disorganized? And I want to use two words here, risk and response. It seems as though quite early on in this particular setting, as COVID was marching across the world, different countries decided to adopt their own methodologies for assessing risk and then for establishing the response they wanted to make. And you saw and still see quite big variations between countries that normally you would expect to be pretty much standing side by side, but when it came to their COVID strategies, they've been very, very different. In some cases, this can be explained through politics, but I don't think it's just political. I can't explain to you why there has been such a lot of individualism. I'm sure people will say it's because WHO has not been firm enough in coming out with standardized approaches. Now, the reason why I think WHO has found it quite hard is that we've been learning about this virus consistently, and we continue to learn about it. It's just not straightforward. It's a coronavirus like none we've seen before, and there's a lot that's coming clear on the nature of the disease, the nature of the human response to it, and then the effectiveness of different control strategies. So I just want to stress that it will get better, and this quite confusing situation on travel will improve when there is more standardization of what is a good response to COVID. What are your 7 core performance indicators for assessing the response and so on? WHO has been really quite clear on this. Don't just do it in terms of measuring case numbers, but do it in terms, as Debbie said, of your capacity to interrupt transmission, or your capacity to keep people at home when you feel that they might have been exposed. It's no good having a system of isolation that nobody will adopt because they feel that they're losing out financially, for example. So standardized performance indicators will greatly help us when it comes to dealing with international travel, and the sooner we get there, the better. The impact of all the attacks on WHO comes in 2 ways. One is the direct and tangible impact, especially around money being withdrawn. But the second is the intangible impact on the degree to which, for example, the institution is trusted by political leaders and public health actors around the world. I think the financial loss is significant because if you take away around 15% of the core budget of an organization like the WHO, you're actually taking away 15% of the people who are in the core positions that keep the place going. Not the people who are running programs, who can usually get funded through other pathways, but the administrative backbone, the communications backbone, the backbone of all the core elements of the organization that keep it going in more than 100 countries around the world. You have to remember that WHO's budget is about 1/3 of the United States Centers for Disease Control, and the place has more than 100 country offices, 6 regional hubs, and Geneva. So, Carol, this is a big hit, and I don't want anybody to belittle it. And compensating for it with what we call project money isn't actually helping. There are people who are going to lose their jobs, and it's terrible. But secondly, the bigger frustration is that if you go on attacking an organization like WHO, which can't really respond in the same style as it's being attacked. You know, if a world leader says WHO blew it, and WHO's in the pocket of the Chinese Communist Party, and WHO staff are sucking up to China all the time. If you've got that stuff coming from a world leader, the #1 world leader really, in tweets, in public letters that are put on Twitter before they even reach you, as happened on the 18th of May, it's really hard to respond. And the Director General cannot respond in kind.
Yeah.
And
often these people are sort of silenced diplomatically, which has its own implications.
Finish, Claire, because I realise I've gone on too long. Just want to say that's what worries me, is the perceived loss of credibility of the place. And everyone here who's a public health person, the 715 people on this webinar, you're all members of the World Health Organization. It's a network of people with shared values, shared intentions. That's taken the hit. It's what we stand for as public health people.
Certainly the pandemic has shown that what health happens over there is entirely relevant to all of us, whether you're in health or not. So that argument has been made clear. I actually want to move on to the public health leadership and management around the world, which you have both touched on already. And I want to consider a bit about the lockdowns. So we've had a couple of questions. I'll combine them from Kusum Siramana, who's a consultant. So the comparison of methodology and outcomes from different countries, what can we learn? And from Dr. Dasmano's consultants asking, is there more than one correct public health strategy? And here I want to reflect on, we had early lockdowns in Asia. We locked down in Europe, and African countries, a number of them also locked down early. Australia's got a sustained lockdown and is talking about a policy of eradication. And Debbie, you yourself has spoken about the opportunity for Scotland to pursue a policy of eradication. Do you think that's still possible now, Debbie?
Well, I guess what I had earlier said is that if Scotland was an island, looking at our numbers in June, we probably could have eliminated it. I mean, we had such few cases for weeks. We had, a handful. And so you could have just expanded your testing and used the summer months to clear the virus and then put in place checks. But Scotland is not an island. And I think it's a challenge faced by other countries. I talked to someone in Germany who said, the country has borders with 9 other countries, and has constant traffic over those borders. So I think what you've seen is islands, which have small islands particularly, have been good at elimination of the virus. I would change the word eradication to elimination, because eradication means getting rid of every case on the planet. So we've done this with smallpox. We've attempted this with polio, and we're getting quite close until COVID-19 hit. And I think it was clear in January, when that moment was lost, when it became spread throughout the world, that eradication was, it just became impossible. Elimination within national borders means stopping community transmission and then trying to get into clusters and stopping the reimportation. And there actually, we have seen a number of countries who have achieved elimination of the virus, or an elimination strategy, which is maximum suppression. You just constantly try to get rid of it, versus some kind of acceptable incidence where you say, okay, we'll keep it at 1,000 cases a day, or we'll keep it at 3,000 cases a day, or we'll kind of try to simmer it at a certain level. And so I think what at least I'm seeing in Europe, including Sweden, including states in the United States, Britain, Scotland, all the different parts, is there's generally agreement on what we call a kind of maximum suppression strategy, which is you don't want to unnecessarily expose people to this virus if you can avoid it. At the same time, you can't lock down people forever, and the costs of lockdown are enormous. And I think one of the mistakes that has been done is that people, were locked down, but there was no purpose to the lockdown. It's like freezing time, and then all of a sudden you lift the lockdown, and you're exactly in the same position you were a few months earlier, except you have massive economic and social costs attached to it. So what is the purpose of the lockdown? And for me, a purpose of a lockdown is to aggressively go after the virus and try to clear it, and try to identify who has it and who doesn't, because all of a sudden people are not socially integrated as they were before, and their contacts fall from, let's say, over 20 or 30 to just a handful. I think looking forward, though, what we have learned over the past few months is where the virus transmits and how you can really get a handle on it. And for me, there's 3 components to what we're going to see in country strategies. We're actually, even as I said, you might consider, Sweden here, New Zealand here. I think we're going to see some convergence now around strategies, which is that you try to get as much economic and social activity going, but you need to have 3 components attached to it. So the first is actually letting the population know about the virus and how serious it is, even for young people. I think there was this idea also espoused by President Trump that children are immune, young people are immune, go out, enjoy your life. And we're seeing that because of the rise in the number of people who are experiencing chronic symptoms to COVID, you might call long COVID, that actually you don't want to have a generation, even if it's 1%, even if it's 0.5% of 30 to 50-year-olds who are not able to work and place a burden on your health services for years and decades to come. I think that's the first component, and this collective responsibility that, young people, yes, they might be fine, but they go home to their parents and they go to work with other colleagues who are elderly, and that a lot of young people have comorbidities like hypertension and diabetes, or are cancer survivors. I was thinking of how many people I know my age who fall into risk groups who actually would be considered high risk for COVID, or who have Crohn's disease, are immunocompromised in some way. So I think the first thing is that there's been acceptance that you can't just shield the vulnerable. I think now people realize, okay, we can't just do that. We have to have a broad collective strategy that we're all in this together. You can't just segregate and separate the population out. The second is you need to get your testing and tracing up. Testing has always been the bottleneck, at least in the UK, that there's never been enough capacity to do the things we would like to do with testing, as well as the technology of the kind of tests you want to have in terms of how rapid they are, how accurate they are. And that's going to be, both the challenge of science to deliver those tests and also the implementation of them. Once you get your testing going and get results back faster, how effective is your tracing? So that's going to be your kind of putting out the fires. And the third component is I think we will continue to see local restrictions. I think that's inevitable now. But these restrictions won't be like what we've seen in the past, which was stay at home, don't move, or the Spanish, which was lockdown, which was you can't even leave your home and children cannot go outside. I think that was unnecessary in retrospect. What we really need to have is, risk-based, which is what are the settings in which transmission takes place? Where are we seeing super spreading events? And if we look across the world, these have generally been religious gatherings, mosques, churches, where a lot of people gather together indoors, bars, pubs, house parties, possibly fitness studios as well. Basically indoor, poorly ventilated, crowded settings where many people are together and have, let's say, longer period of time together, an hour, 2 hours, and where one infectious person can infect dozens of people. And all of a sudden you have a super spreading event and your testing and tracing gets stretched and you get these clusters taking off. And so we probably will see restrictions, but I think they will be of the type that we're starting to see in Britain, which is around gatherings of indoors, as well as around pubs, bars, hospitality, indoor events. And so I hope that will give people hope that even if we were going to have another national lockdown, I don't think it'll look like the one in March, because we've learned so much about that. I mean, the other thing that was, I think, surprising to me and continues to be shown is actually schools are not super spreading events. Schools seem to just be a mirror of community transmission. They are not bubbles, they're not super spreading events, they're kind of in the middle. So if you can keep your transmission low, you can keep your schools open. In Scotland, schools have been open a month, and yes, there have been cases in school. Yes, there's been a cluster in school. Yes, there have been clusters among teenagers, but the vast majority of schools seem to be fine and operating. And so I think there is a way to keep schools open through this, which is another big concern of the educational impacts, and that countries need to balance, how do we keep our numbers low enough to keep schools going during this time? And I think that's, looking at the United States from afar, that's one of the tragedies, that so many children are not in school because they haven't managed to get a handle on the community transmission. So if you manage your community transmission through these mechanisms, you can have a lot of your economy and society going, a lot of movement, a lot of interaction. Probably not to the level we had pre-COVID. We're not going to be having concerts with 1,000 people, but way off from where we were, which was, you're staying at home for weeks on end and not seeing anyone outside your household. So it's going to end up being, I think, this kind of balanced perspective, which is taking what we know about the virus and trying to keep it low, but in a more targeted way.
Thank you, Devi. And in fact, it reminds me of what David has said here, but also earlier in spring when he says we have to just get used to living with this virus. I just want to bring in that we've addressed some of the questions here. We'd had a question from James Graham about schools, colleges and universities all being back. And he's wondering why the UK government hasn't emphasised the need for better ventilation and detectors, I think it's CO2 detectors, I guess, in terms of establishing the closeness of people working. But you've addressed that in terms of, at the moment, we have seen relatively few events of spreading and outbreaks around schools. They are happening, but they are relatively few. We've also had a question from Gary McFarlane saying that Europe is experiencing an increase in cases again over many weeks, but not hospitalizations. Is it time to become less cautious? And we have addressed that in terms of the particular population among which that spreading is happening at the moment, but of course we know that it will move. Given the fact that cases are among the younger population in Europe at the moment, David, do you believe that herd immunity may become applicable to COVID? There's a question here related, which is the government's goal at the beginning of the pandemic was to achieve herd immunity. Is it possible to achieve this, or will we be alternating between relaxing and enforcing restrictions until we find a vaccine?
Thanks a lot. Personally, as I look at the results of serological surveys, I do not see a rapid build-up in levels of population immune response. I don't really want to say immunity, that would imply that banking on population immunity is a sensible strategy. So if I was to shorten my words, I would say a strategy that is working for herd immunity is, I believe, both dangerous and irresponsible. So I don't think that that is going to come. Just a couple of other things. I would like to really echo what Devi has said. I like the way in which she presented what I see as firm strategic principles that apply everywhere. There's no case for having different strategic principles in different settings. but you can apply the same strategic principles differently in a way that's adapted to context. But overarching strategic principles seem to me to be standard for the whole world. And my second quick comment is, in developing responses, it's worth remembering that it's the virus that is the enemy, and it is people that are the solution. It is never people that are the enemy. And so it's really, really important for all of us involved in this, particularly given that we're in it for the long haul, to make absolutely certain that we reach out to and engage all groups, particularly those who might be at high risk, and bring them in as really fellow workers in the response, rather than as people who are treated with perhaps derision and accused of being irresponsible. That's not going to be helpful at all.
Thank you, David. I do have a couple of questions that I should put to you. The first is from Bertie Lee. It's a legal professional asking, do you think a properly resourced, wholly independent statutory equivalent of PHE would have handled our response differently? And from Mark Glasgow, who's a retired GP, why was the UK so badly affected? Can I put that to David first?
I'm rather hoping that that question might go to Scotland, because, but I'm going to take it. Everybody, my current job as envoy for the World Health Organization, it's a kind of honorary role, and I love it. And one of the things that I've tried really hard to do, I haven't always succeeded, is to avoid making any direct critical remarks about any government, as I think it's kind of unhelpful. So these two questions are really quite UK specific. I have no idea whether a differently financed and governed PHE would have reacted in a way that perhaps leads to an alternative outcome. So much depends, not so much on the governance arrangements, but on the approach to leadership when you're dealing with these issues. And whatever is said when the analyses are done subsequently, the one comment that I will have generally on leadership on COVID responses is that I feel that it's not always been collective leadership. It's not always been leadership that acknowledges the interdependence of actors, particularly at local level. And perhaps now that's really coming through as we see more and more understanding that locally integrated, data-driven responses that engage populations where there are spikes building up are more likely to be effective than responses to a local problem that are driven entirely from some central source. So a PHE that was able to draw on the massive devolved capacity that there is in the UK public health community could have been a really, I believe, fantastic force had it been able to be unleashed in support of locally integrated responses.
Yes, thank you.
And I think the other question I'd probably just not want to answer.
Fair enough. Devi, can I welcome your insights?
Yes, I guess I can speak a bit more openly. I think in the UK, there were two strategic errors. And the first was to pit the economy versus health, which David talked about at the start, which was the feeling that, oh, we don't want to hurt the economy by putting in restrictions early. And so let's try to already start to trade it off, where I think the countries, I mean, Taiwan is the textbook example, who immediately control the virus, have had swifter economic recovery. And now it's been fascinating talking to economists like Sir Tim Besley, Sir Nick Stern, and others, Jonathan Porter, others who are all saying the same thing. And this is from economists, which is like get your public health sorted, control the virus, make things secure, and you'll get your economic recovery. If you're trying to do both, you'll drop all balls in a sense, and you're not, managing any situation appropriately. And I think that was true. And the second was to follow the 2011 pandemic flu plan. And if you read that plan, actually a lot of what the government did in March makes sense, which is that you don't test for every case, you don't continue contact tracing, you don't try to disrupt people's lives, and you try to build the healthcare capacity to basically treat people and manage your way through the pandemic. You see it's uncontrollable, and the virus being that everyone's gonna get it. And if you read early on, one of the architects of Sweden's plan did a Lancet article explaining Sweden's approach, and he said something similarly as well, where he said, look, it's uncontrollable. We expect in Sweden, everyone will be exposed to this. Every country will face the same amount of deaths per capita. It'll all depend on your health service capacity. And so the whole goal is to stay within health service capacity and do minimal restrictions going through it. And I think already we've seen that kind of approach. There's no sense in front loading deaths because we've had, major breakthroughs in treatments to save people from dying. So actually fatality has come down. So I think, I won't go into kind of the what happened since then, but I think if you understand the broad perspective of where the strategic advice was coming from and what they were thinking, then it makes more sense what followed. So I'll stop there.
Yes, thank you, Debbie. And it reflects conversations about the advising groups to government, sometimes lacking those who are on the front line, operational public health practitioners. We had a session with Ivan Brown, the DPH, the Director of Public Health from Leicester, a few weeks ago, and his insights from actually knowing locally his population were very, very valuable, and his experience of managing with central systems. I just want to mention here a question, and we can't put it to you now, but I'll turn it to a comment from pharmacist Trudy Hilton, who says, how can we ensure more joined up working linking chronic disease management with infectious response? We need to do that better. We need to be wrapping up shortly, but I really must ask you, in terms of planning for a more secure future, can I come to you, David? How do health leaders advocate for a richer and more equitable future for populations and for the planet, given the fact that as and when we continue through this pandemic and emerge from it, there are real opportunities that we need to take for change? David.
As public health professionals, our value system is really quite straightforward. We work for health of all people, regardless of their nationality, their ethnicity, and any other defining attribute. And the fact that we are doing this and that we are proud that this is what drives us makes us incredibly important actors in the effort to establish a more equitable and sustainable world. I'm guided all the time by something called the 2030 Agenda for Sustainable Development and the Sustainable Development Goals. But I feel proud to be doing my work on that as a public health person, because it means that if anybody pushes me and says, well, what are your defining values? I can be very straight with them. I'm not tangled up in intergovernmental politics. I'm not representing any particular faction. I am just working for the public good in the purest possible sense. By the way, that doesn't mean I've got any special attributes that makes me pure, but I do think my values are helpful. So as a health professional, it is my duty to help all who are working for those people who are not able to enjoy good health, whether it's because of climate change, because of the destruction of nature, because of really grotesquely unethical warfare, because of really discrimination. It is my duty to work for those. Every single health professional ought to be taking a stance on all the major existential issues of our time. Come out of our health straitjacket. Stop seeing ourselves as bounded by the structures of the health professions. Become freer and looser and work for the well-being and equity of opportunity for the totality of humanity, and then work with people in other sectors to get that outcome. We've got so much more to do, and on all these issues, I wish we could be stepping out, standing up more, and then working right across the Sustainable Development Agenda.
David, thank you. I love your call for public health activism. I hope we can live up to that call. We really must do so. And so I regret that we must wrap up now. I've gone a little over time. My apologies to you as the audience. Your questions are all read. They are all valued. I know that we failed to address many of them that come in live. We have a number of questions that come in when people register for the webinar. And I've tried to build in as many as I can of those. We will be looking at the others and discussing them in our wrap-up panel in due course. A recording of this webinar can be found on the RSM Live website. It's going to be available within 48 hours to be able to freely watch. And there's a survey at the end of this. We'd love you to share your comments and feedback and let us know what else you would like to see in our series as themes and topics going forward. If you've enjoyed this webinar, please do consider becoming a member of the RSM, supporting our work through this outbreak and beyond. And indeed, if you are a member, 1 Wimpole Street, our venue, is open, its facilities are open, and it's all in relation to the government's guidelines being adhered to. And so Devi and David, it really is my pleasure to share this time with you, to gain from your insights for the benefit of our population. And may I wish you and all listening a very wonderful afternoon ahead. Thank you.